Hi, my name is Mary Sir. I'm a revenue cycle and coding consultant with M2 Revenue, and today we're going to do a 10-minute coding camp on interprofessional consultations. In this session, we're going to be learning about the different interprofessional consult codes. We're going to look at the documentation and billing guidelines for this code set, and we're going to do a scenario review. So what is an interprofessional consult? It is very similar to what we would consider a face-to-face consult in today's healthcare environment. So it's when a treating physician asks the opinion of a specialist on diagnosing and treating a specific problem. So you have the request, you have the rendering provider, and you have the report back to the treating provider like we do with regular consults. But unlike traditional consults, it is not expected that the consulting provider is actually going to see the patient. So they're going to discuss with a treating physician, but not physically see the patient. These consults can be done via telephone, internet, or health record assessments, which is another thing that separates them from face-to-face consults. In this slide, we're actually going to look at the CPT codes for the interprofessional consults. So you'll notice that the first four codes in the table have a star beside them. And it says that the focus of these codes is counseling and coordination of care, and that greater than 50% of the time must be in discussion and review with the treating provider. Now, these codes have been in place for a few years, and again, they require both a verbal report and a written report. So it must be clear that there was a discussion with the requesting provider and also a written report sent back to that provider. So you can see in the last column the work RVUs that are associated with each of these codes, and they vary based on the number of minutes spent in discussion and review. The last two codes in the table are relatively new. I think they've been out for a couple years. And these really focus more on data analysis and looking at records, looking at MRIs, whatever you need to look at, and creating that written report back to the provider. So 99451 is interprofessional consult 5 minutes plus of consultative time. And again, that's whatever it needs to be for you to be able to complete the consult. It does not say that you can't talk to a provider, but it's really just saying it's 5 minutes or more of that consultative time. And then you can see the work RVUs associated with that. A verbal report is not required, but a written report back to the requesting provider is required. And then there's CPT code 99452, which is a new code and a new concept that the requesting provider also gets RVUs for taking the time to review with the consulting provider, look at the record that's coming back, and that is 16 to 30 minutes of time preparing for the consult and then reviewing the content or the data analysis that comes back from the consult. So this is completely new concept that whoever's requesting the consult can also get RVUs depending on how it's documented and how it is done with the requesting or that consulting provider. So here are just a few quick tips about documentation guidelines for these interprofessional consults. The consulting provider, so that's the one who's doing the consult, must document which treating provider requested the consult. So this is exactly the same concept that we have when we have face-to-face consults. It must be clear who requested the consult. The medical record must show written communication back to the requesting provider via sharing a note in the HR system or a letter. So that's regardless of the code set used, because every one of these code sets requires a written communication back to the treating provider. So for the 99446 through 9, the verbal discussion must also be documented. Verbal or written consent from the patient and family for the consultation must also be obtained. And we're going to talk a little bit more about that in a different slide just to discuss why that's important. And then the last one, I should put it in bold, time statement, time statement, time statement. All of these codes are time-based. We have to know how many minutes were spent doing the work so that it can be coded correctly. You need to describe what was discussed, and you can also add multiple days. So if you spent 15 minutes on day 1 looking at the MRI and you spent 10 minutes on day 2 discussing the MRI, you can add those minutes together. And this is one of the very few code sets that you can do that for. It's over a 7-day period. However much time is spent in that consult can be added together. So this is just a quick slide about consent, and consent is important for any service being provided, but it's especially important for interprofessional consults. Why it's important is because the patient and family is potentially never seeing the consulting provider, nor getting the report that the requesting provider is getting. So if the patient has a high deductible plan and they get a charge or a bill for this service, they're going to wonder why they're being billed because they never saw this particular provider. So when we talk about doing consents and things like that, it's just really important to put yourself in the patient's shoes and think about what they're going to see on the other side in their statements and make sure that everything lines up correctly. So here are a couple other general billing rules for the interprofessional consults. The consulting provider must be a physician. So the person who is doing the consult has to be a physician because that's in the CPT code definition. The treating or requesting provider can be a physician or APP, which is a PA or nurse practitioner. They may be a new or established patient for a new or existing problem. The consultant may not have had a visit with this patient in the last 14 days. And then the interprofessional consult cannot lead to a face-to-face visit within the following 14 days or next available appointment. And again, 50% or more of time must be spent in discussion for the CPT code set 99446 through 449. So here are some more general rules. It can be reimbursed in a facility and non-facility setting. It cannot be used for transfer of care. If multiple calls and reviews are done, I think we mentioned this in another slide, add up the time and bill on 1 day of service with documentation of total time spent for a period of up to 7 days. Interprofessional consults of less than 5 minutes should not be billed. The treating provider time less than 16 minutes should not be billed. Treating provider time of greater than 30 minutes should be billed with prolonged service codes, and which code set depends on if the patient is on site or not. The provider must be enrolled in the plan being billed, so it is difficult to bill for these if you're doing an out-of-state opinion or looking at an MRI for a colleague in a different state. If patient and family communication happens, you can bill with other CPT codes because there are another CPT code set for how you're communicating with the patient and family. Okay, here's your first scenario. The neurologist asks the neurosurgeon to review an MRI for possible surgical intervention. The neurosurgeon reviews the MRI and writes a recommendation back to the neurologist. No intervention is needed. The neurosurgeon documents 20 minutes in total consultative time. How do we bill for this neurosurgeon? The answer is CPT code 99451. Again, because there is no documentation of a discussion, and the neurosurgeon documented 20 minutes in total consultative time. So that's what we would do in this scenario. Here's a different part of the same scenario. The treating neurologist from scenario 1 documents 25 minutes in preparation and review of neurosurgeon report. How do we bill for this neurologist? And the answer is CPT code 99452. Because again, we're not seeing any kind of discussion. This is the treating neurologist, not the consulting provider, and they documented 25 minutes in preparation and review of this consult. Here is scenario 2. A gastroenterologist is asked to evaluate the lab results of a critical care patient who is improving. The GI doc reviews the labs and tells the treating physician to have the patient follow up in her outpatient clinic ASAP. How to bill for the gastroenterologist? The answer to that is it is not billable. And the reason why is because the gastroenterologist is going to see the patient as soon as possible and will obtain the RVUs from that clinic visit, so they are not able to bill for the consult code. Here's one other scenario. A hospitalist asked an infectious disease doc to review labs and plan of care for a patient with COVID and recommend treatment. The ID doc reviews the results and documents 35 minutes in discussion with the hospitalist who is on the floor with the patient. How to bill for the ID provider. And again, because there is discussion, it is CPT 99449. We have 35 minutes documented in discussion with the hospitalist, so we can use the CPT code set that has both a verbal and written report, assuming that the ID doc is going to share the written summary with the hospitalist in their EHR system. So here's a different take on that scenario. The hospitalist documents 35 minutes in discussion on the patient floor. How do we bill for that? And the answer is that we need to add the time to the E&M code that the hospitalist is billing for the day, because the hospitalist is on the patient floor and the time spent is greater than 30 minutes. So we would add that time and also bill for whatever base E&M code the hospitalist has billed for the day. So that's all the information we have for this training. I would be more than happy to answer your questions. Feel free to send those to question@m2revenue.com, and I'll be glad to get back to you as soon as I can. Thanks for watching.